all right? And then after I get this part done, we'll bring Clint in and we'll talk about I think there are really some good war stories and anecdotes that you might find useful if we get confronted with this. So dabigatran is Pradaxa. And then you have, they got some real fancy names. And then you have, now Pradaxa is a direct thrombin inhibitor. It's a DOAC, but it's a direct thrombin inhibitor. Xarelto is a factor 10 inhibitor. And then you have Eliquis and this new one, Savesa, which I've never heard of. But let's look over here, indications for use and frequency taken. So it's used to prevent stroke caused by AFib. You take it twice a day. It's also used to treat DVT, blood clots or PEs. Take it twice a day. And the major side effects are bleeding, not surprising, and stomach upset. For Xarelto, again, for stroke prevention and AFib, and for treatment of DVT and PE, major side effect, bleeding. Same thing with Eliquis and with this other one. But of course, the major side effect is bleeding. Well, the major side effect of warfarin is bleeding too, of Coumadin. So, that's their major side effect. So what is going on with these things? Well, first of all, why did DOACs even become popular? What's the point of all of this? Well, warfarin or Coumadin was discovered in the 1920s. And there were these cattle that were basically dying of this very unusual hemorrhagic disease. And it was identified to be from the moldy silage that was made for cattle feed out of sweet clover. And so that's how Coumadin ultimately was discovered. And Coumadin is reversible with aquamaphytin, vitamin K. It's a vitamin K agonist. But DOACs are, first of all, more predictable when you give them. And that's, again, what's leading to their popularity over Coumadin. You do a valve on somebody, a mitral valve on somebody, and they're in the hospital for 4 days, 5 days, 6 days, 7 days while you try to get their INR where you want it to be. Coumadin is just a very unpredictable drug, and it's got a really long half-life as well. But DOACs are much more predictable. They do not require routine lab monitoring. DOACs have fewer dietary restrictions. If you look at the ads, you'll usually see on one of them, I think it's Eliquis, or it may be the other one, but you see them eating salads. And in fact, you have to, if you're on Coumadin, you have to avoid vitamin K rich foods because it's an antidote. It's going to affect your INR. It's going to lower it below therapeutic value. And that includes some really good stuff. Avocados, green apples, green grapes, honeydew melon, kiwi. I love kiwi. Limes. What goes better with tequila? Green pears, artichokes. I love artichokes. Arugula, asparagus, broccoli, Brussels sprouts, cabbage, certain types of cabbage, green beans, celery, cucumbers, Belgian endive, and kale. I mean, it's incredible that of all of the things, and this is just a partial list. There's other things, but this is a lot. So it really has an effect on the quality of your life, and that's really what's making DOACs more popular. They also have a much more rapid onset than does Coumadin, and a significantly shorter half-life. All of those things are very important. So let's take a look at this. So with Pradaxa, dabigatran, the first one on the left, it targets factor 2A, thrombin, direct thrombin inhibitor. Is it a prodrug? Yes, which basically means that it's a compound that could be inert but doesn't have the desired effect until you take it, and it's the metabolite that is what becomes the pharmaceutical that you're trying, or the drug that you're trying to give the patient. So that's just what that means. Bioavailability, how much of it is available in percent when you take it? Only 3 to 7%, unless you chew it or break open the capsule. So, that could have an effect too. Time to peak plasma concentration is 1 to 3 hours, delayed by food. Half-life is 12 to 17 hours compared to Coumadin, which is 40 hours. Dosing frequency is once or twice daily. It is 80% renal eliminated, unchanged. It is dialyzable. This is very interesting. This is something let's look at all of them. We'll talk about it. But protein binding, 35%. Let's look at Xarelto, which is the rivaroxaban, or whatever, factor 10A inhibitor. It's not a prodrug. Bioavailability is 66 to 100. 2 to 4 hours, time to peak plasma concentration, delayed by food. Half-life is 5 to 9 hours, 11 to 13 in the elderly. Once or twice a day. Renal elimination is only 36%. It's not dialyzable, and the protein binding is 92 to 95. See where I'm going with this? I'm going somewhere with this. And then Eliquis, again, another factor 10A. Bioavailability is about 50%. 3 to 4 hours, time to peak concentration. Half-life is 12 hours. And now if you know that your single dose of Pradaxa or your single dose of Xarelto is going to give you a plasma concentration of X based on bioavailability, whether it was taken from food or how long it's been since you took it. Now, with the math that I gave you, you can go back and tell what the actual half-life will be until it is no longer at therapeutic value. So see, that's going to be of a benefit to you, I think. I take it twice daily. Renal elimination is only 27%. It's not dialyzable. Protein binding is 87%. So where was I going with that? Is it dialyzable? What makes something dialyzable, or using CRRT or some other iteration of renal replacement therapy? What makes it that? And that is not being protein bound, because you're only taking plasma water out. So it has to be water soluble, can't be protein bound in order for it to be dialyzable. So Pradaxa, if you had a patient who was on a massive dose of Pradaxa, overdosed on Pradaxa, and you got them on pump, and you know at the end of this case there's going to be massive bleeding, you can actually remove it by dialyzing them or doing some kind of ultrafiltration with replacement fluid, sort of CVVH, on pump, and remove pretty much all of it. So that's a real benefit there. The others, you have to do some other fancy stuff, and it's risky business. It's a real problem, and you'll see that moving forward here. Watch this ad.
It was here. I couldn't catch my breath.
It was the last song of the night. Felt like my heart was skipping beats.
I went to the ER. They said I had AFib.
AFib? What's AFib?
I knew that meant I was at a greater risk of stroke.
I needed answers.
Once I got the facts, my doctor and I chose Xarelto.
Xarelto, to help keep me protected from a stroke.
Once daily Xarelto, a latest generation blood thinner, significantly lowers the risk of stroke in people with AFib not caused by a heart valve problem. In a clinical study, over 96% of people taking Xarelto remain stroke-free.
Xarelto works differently.
Warfarin interferes with at least 6 of your body's natural blood clotting factors. Xarelto is selective, targeting just one critical factor. For AFib patients well managed on warfarin, there is limited information on how Xarelto compares in reducing the risk of stroke. Don't stop taking Xarelto without talking to your doctor, as this may increase your risk of stroke. While taking, you may bruise more easily or take longer for bleeding to stop. Xarelto can cause serious and, in rare cases, fatal bleeding. It may increase your risk of bleeding if you take certain medicines. Get help right away for unexpected bleeding or unusual bruising. Do not take Xarelto if you have an artificial heart valve or abnormal bleeding. Before starting, tell your doctor about all planned medical or dental procedures and any kidney or liver problems.
Learn all you can.
To help protect yourself from a stroke.
Talk to your doctor about Xarelto.
Okay, so if you take Xarelto, you go to hockey games and you can play the guitar and you have fun. This ad was from
This Legal Minute is
same
brought to
day
you by Drug
that
Lawsuit
ad
Source,
aired,
the
within
leading source of
just a few
news
hours
on
of each
dangerous
other.
drug and defective medical device lawsuits.
Xarelto blood thinner medication is used to help prevent the risk of stroke. Xarelto was approved by the U.S. Food and Drug Administration in 2011 for patients who had knee or hip replacement surgery in order to reduce the formation of blood clots. Later that year, the FDA expanded approval of Xarelto for patients suffering from atrial fibrillation. In 2012, the drug was fully approved by the FDA for general treatment of deep vein thrombosis and pulmonary embolism. Xarelto works by preventing the clotting of blood. However, this clot prevention can cause uncontrolled internal bleeding because the bleeding cannot be stopped until the drug is completely out of your system. The results are often serious and even catastrophic, especially when this happens near the major organs like the brain, kidneys, and lungs. The most serious side effects of Xarelto are blood clots, brain bleeds, cerebral hemorrhage, eye bleeding, gastrointestinal bleeding, liver cancer, stomach bleeding, stroke, and vision loss. These side effects can range from mild to life-threatening. Our dangerous drug lawyers are currently investigating lawsuits against the pharmaceutical company that makes and sells Xarelto. These lawsuits demand compensation for your physical and psychological harm, disability, lost wages, and medical expenses. Claims for wrongful death may also be pursued by surviving family members. To find out if you are eligible for a Xarelto settlement, contact the Drug Lawsuit Source hotline now at 866-280-4722 for your free, no-obligation case review. Our award-winning lawyers will listen to your story
Award-winning.
and get started on your
Award-winning
case
lawyers.
immediately. There are strict time deadlines for filing claims, so you need to act immediately to get your settlement. There are absolutely no legal fees until you receive your settlement, and our legal team will pay all of case costs and litigation expenses. It literally will cost you nothing to get started. If your case is unsuccessful for any reason at all, you owe us nothing. We put that in writing for you.
They put it in writing. Okay, so a couple of things. One, I'm a perfusionist. I have had a cerebral hemorrhage and a stroke at work several times, and I didn't even take Xarelto. But the one thing she said that was, I think, important in all of that was you can't stop the bleeding until the drug is out of your system. And so, again, let's go all the way back in the Wayback Machine to one of my earlier slides, first couple of slides, with that case of the 300, 600, 900 of Plavix, and now depleted blood bank of platelets. We're shipping them in from all over the regional area, trying to stop the bleeding. And that's where the problem comes in. That's really the issue. I mean, you want to have a DVT and a PE, you want to have a stroke from a clot that's in your left atrial appendage because you're in AF versus, the risk of bleeding? Well, of course not. I mean, this thing is ridiculous. This is what's wrong. I mean, I don't want to get off on a political discussion here because that's not what this talk's supposed to be about, but it's fundamentally wrong. Both Big Pharma and the way they present their medications or their pharmaceuticals, sometimes they're not really medications, but they're pharmaceuticals, they're products, or it's these crazy lawsuits. I don't know where the balance is. I'm not sure. I'm sure there are some people that do things that are nefarious, and I think that there are certainly not an underwhelming number of frivolous lawsuits out there. And this, I just don't know what to do. But it's why drugs are so expensive. And sometimes really good drugs are taken off the market unreasonably, unfairly, and to patients' detriment. As well as drugs being on the market that should have never made it to the market. So, it's a free-for-all out there. But I thought it was interesting that both ads played on the same day within just a few hours of each other, because they're still advertising for Xarelto, Eliquis, Pradaxa. They're still advertising for them to ask your doctor about it. And there's a lot of people on Coumadin right now, going to the Coumadin clinic that want something different, because Coumadin is essentially, it's rat poison. Okay, that's really what it is. Then you have the lawyers saying, oh my God, if you died and you were taking this almost for any reason, it's probably a result of that. So, it's craziness. So here's my case. Emergency CABG. Patient is taking routine direct oral anticoagulants. Now what do we do? Do we really know what to do? You do if you watch PerfWeb. Because I'm going to give you something that you can take home with you and have and look at. And it's basically, what do you do? If there's no rush for surgery, that you don't expect any bleeding for greater than 24 hours, and the bleeding is only going to be minor. If it's the direct thrombin inhibitors, Pradaxa, that's the dabigatran on the left. If it's the other ones, the factor 10A inhibitors, the Pradaxa, the Eliquis and the Xarelto and the other one, then it's on the right column. But you withhold the drug. If it's withhold the drug, monitor clinical status, and recheck lab tests. If you're going to expect expedited bleeding, 1 to 24 hours with major bleeding, it's going to be expedited, so it's short duration of time. Withhold the drug, give activated charcoal, and that's the activated charcoal, of course, would be to absorb the amount that has not yet been digested. If last dose was taken within the past few hours, and you give this drug, if it's not available, I can't even say it, consider prolonged hemodialysis, because greater than 2 hours, because that's not really prolonged, but that's what they call it. That will certainly remove it. If active bleeding persists after this antidote, or it's not available, consider low-dose prothrombin complex concentrate 3 or 4 if 4 if the 3 is not available, and 25 units per kilogram IV with titration using additional doses to desired effect. Now, that's a lot. You can read the rest of them, okay? And the other one basically says if it's emergent, pretty much the same thing. The difference being that with the Pradaxa, you could do the dialysis on pump or some form of it. With the others, it's of no value to do that because it's protein bound, so that's not going to do anything with it. But when you give these either antidotes or these prothrombin complex concentrates, there's a lot of risk associated with that, a lot of risk of thrombosis. They're dangerous, can be, and they're usually reserved for really, really, really bad bleeding. But if you've done a type 1 dissection, you may have really, really, really bad bleeding if the patient is, in fact, factor 10 inhibited by one of these drugs. Again, very good to know what the half-life is. Hope you have good renal function and hepatic function, and figure out, hey, how long since his last dose? How long is it going to be before this is cleared? It may be worth staying on pump, if you think about it, and controlling the blood volume at least, because you can do that instead of trying to come off pump, give protamine, and then bleed, cell saver, bleed some more. Because you do the cell saver, you give red cells back to plasma, the platelets are gone, bleed, give more and more and more. And then you run into all kinds of problems associated with that too. So you may just be better off staying on bypass. So 3-factor prothrombin complex concentrate products contain 3 factors, 2, 9, and 10. The 4-factor contain 4, 2, 7, and factor 7, that's the one that makes everybody really nervous, 9 and 10. activated prothrombin complex concentrates contain 4 coagulation factors, and the factor 7 is in active form. The others are in inactive form. So that's important to know. And that just makes it more potent. So another thing you need to be concerned about is the danger of relying on PT-PTT in patients that are on DOAC therapy. And you can read this from 2016, 112 patients. So for the direct thrombin inhibitors, the degree of PTT prolongation varied across reagents and correlated poorly with drug concentration, with normal PTT results seen with select reagents at low drug concentrations, while the sensitivity of the PTINR was low for Pradaxa presence. For the Eliquis and the other factor 10As, Xarelto, the degree of APTT prolongation varied across reagents, and while the PT-PTT tended to prolong in a concentration-dependent manner, overall the correlation was insufficiently sensitive. So you've got to remember that you may have a patient that's bleeding. The PT-PTT may not look that bad, or you're treating it based on some number. But is it really the number? And I think what this tells me is PT-PTT is unreliable. I'm not going to rely on it for patients who have been given either direct thrombin inhibitors or factor 10 inhibitors. So what do we do? Well, is the TAG of use? I really don't know. But if you tune into the program on December 11th, we're going to have a pathologist, a blood bank specialist, but pathologist here in the studio on December 11th to talk about TAG, or hematologist, to talk about TAG. And I think that's going to be a really good program. And I'm going to ask them about this very thing and TAG. TAG is sort of always languished out there. It was labor intensive. It was very user dependent. It had a lot of variability to it. You have to draw it. You got to get it run right away. The sample degrades too quickly for it to be an accurate sample. A lot of issues with it, but it's becoming more and more automated, but yet it really has never caught on. It makes sense to me. I think it's the information is very valuable, and with the automation of it, it seems like we should be going more that direction, but I don't see it as much as I would have thought that I would have by now. Anyway, lots and lots of transfusions. You're going to be given either those prothrombin complex concentrates, you're going to be giving FFP, cryo, and so forth, and then you're going to have to worry about red blood cells because you're going to be bleeding. You're going to give those and FFP, then you're going to develop transfusion-associated circulatory overload and other transfusion-associated morbidities such as TRALI and other things. And then, of course, you can use CVVH and dialysis for either volume management or for dabigatran clearance. So you have that as an option. So let's talk about all of this. Let's see what my colleague think we're going to take another quick break, 5 minutes, and then we're going to come back. And when we come back, I'm going to be here, and Clint Robertson, perfusionist extraordinaire, good friend of mine, worked with him for years. And he's going to be coming to us from Alexandria, Louisiana. And we're going to talk about this and, again, some anecdotes and maybe some war stories of some of the things that we used to do. And it may take a completely different path by the time it's all said and done. I'll check the YouTube chat and see if anybody has had anything to say. Or if anybody answered the question, since I've already given the answer, because they just really want this very stylish cup. I love drinking my coffee out of this cup. It's not coffee though. But we'll see you back in 5 minutes with Clint. Hello and welcome back to the PerfWeb program. I'm going to be bringing in my good friend and colleague who taught me a lot. Great guy from Alexandria, Louisiana. What was that? That was interesting. But anyway, I'll be bringing him in just a second. But listen, I was asked by our technical advisor to let you guys know out there that sharing us, liking us on Facebook, liking us on the Twitter, all that kind of stuff is really, really helpful to us, because every time you do that, whether you share us or you like us or you subscribe on YouTube, whatever it is you do, those different organizations see that as people wanting to watch our program, and so, or wanting to share it, because that's a sign that you're doing something good. So in order for us to be successful and to grow and make this better and better and better for you, it's really important. So I'm asking you as a favor, if you've got the Twitter, if you've got the Facebook, if you've got the YouTube, subscribe on YouTube, like us on Facebook, and follow us on the Twitter. And it would be greatly appreciated by me. Okay, so let's bring Clint in if we can. Nope, that's not Clint. That's me. Hold on. Did we lose him? Oh, there he is. Hey, Clint.
Hey, Joe.
How are you?
Good.
Man, I haven't seen you in a while.
I don't know if that's a good thing or a bad thing, huh?
Oh, I think it's a good thing. So how's life treating you?
I can't complain. The only thing that kind of disturbed me was your comment earlier about how much you like onions. I feel more sorry for Vicky now that I know that, but
they're good, man. I like garlic too. That's good for you too. But that's a really neat list. If you go back and take a look at that list, I think you'll really see a lot. Let me just ask them something. Hey, can you guys just change that one thing back there for me? And maybe do it to something, put something else on there. I'm not sure what to do with it. But listen, so how has work been going for you guys over there? I mean, are you guys seeing any issue with staffing or anything like that, or recruiting or retaining or whatever it may be out where you're at? You're in Alexandria, Louisiana, so you're working at Cabrini Hospital, Rapides. And then you also, I think, go over to Mississippi and sometimes to Colorado that I know of.
Correct.
So what are you seeing in the perfusion market right now?
I think there's job openings galore. When I first came out of school, salaries were on the low end because the market was flooded so badly. And I think, here recently you see more of a trend in the opposite direction, where salaries are on the rise because, there's less and less perfusionists out there, especially, those with experience to work at, some of the bigger places like, you work at, or, at least to be in a setting by yourself. I think, with the way the market's going, I mean, sooner or later, of course, that's going to come full circle and, I'll catch back up. But, generally speaking right now, I mean, that's what I'm seeing. I mean, salaries on the rise, shortage of perfusionists, and, complete, 180 from, where I came out 13 years ago. Yeah,
I remember. Yeah, it was a little different. How serious, well, let me ask you this, how significant do you think the shortage is? You look at heart surgery, and right now they're saying that there is like a massive, a very significant, almost a public safety hazard shortage of cardiac surgeons, with that anticipated to be worse. Do you think we're at that level, or do you think we are trending? Where do you think we are in that, and where do you think it's going to be in the next, let's say, 2 to 5 years? Do you see the pendulum swinging already, or do you not?
That's a good question, Joe. And it's one, I could probably, if you want my opinion, I can give you that. But, I remember when I started school.
Because I wanted your opinion.
Hold on, say that again?
I said I did ask you because I wanted your opinion. Exactly. That's why you're here.
For what it's worth. When I first started school, of course, they kind of told us the same thing. Are we going to have a job in 20 years or 30 years? Is perfusion going to be faded out? What's going to happen? So forth and so on. And I mean, are we stenting more in the cath lab? Yes. Do we do less, I guess, single vessel, double vessel cabbages than we used to? Yes. But I mean, with TAVRs and ECMO for the meantime, I guess. But all these things, I think if it shifts from one direction, you gain it in another. So I don't know if we're any further off in one direction as we were before, or we're still in the balance. It just with something else, if that makes sense.
Mm-hmm. No, it makes perfectly good sense. What do you think about ECMO? Where do you think? Because right now, of course, we're just now kind of entering into ECMO season here in Houston with the winter coming, and I'm certainly anticipating seeing the obligatory VV ECMOs from pneumonia, ARDS, and sepsis, and all that kind of stuff coming up pretty soon. And so, and we peak probably around late December, mid-January, and then it starts to trail off again. But what about you guys out in Louisiana or in Alexandria? Are you even doing ECMO yet, or do you not do it at all?
No, we're not doing ECMO here where we're at. There was, a talk a few years ago where they were going to try to get ECMO program up and running, but I can assure you that that's probably on the back burner with reimbursements being cut the way they were. So
Man,
I don't think that's going to happen anytime soon.
I don't know if anybody knows about that, or not, but the reimbursement, the base payment for a VA ECMO with peripheral cannulation or VV ECMO with a single cannula or double cannula, whatever, base payment was about $101,000. And that included if you had a sternotomy, couldn't wean off pump, and went on central cannulation. But it has been cut for VA ECMO, if you're not doing active CPR, down to $8,500, $8,800 if you're doing active CPR. And for VV ECMO, cut to $35,000 unless you're septic, and then you get it to $38,000. So you talk about draconian cuts, and I think that's a public safety hazard. What say you?
No, I agree with you 100%. And I was actually going to kind of lean into that and ask your opinion on that. I think not only well, it is, I guess, all across the board from a patient standpoint. I mean, when you have these programs, in these rural areas, or even in big areas, like Houston, where you're at, man, that all these patients, are coming in counting on this technique to be available if need be. What's going to happen? How many of these programs are going to shut down? I mean, can hospitals continue to maintain an ECMO program with losing that kind of money? I mean, I say no.
I think you're right. I think it's going to be very interesting to see how this plays out. But I think from a public interest perspective, I think you hit the nail on the head, and that is that people expect for you to have technology that is life-saving. Not everybody, but for VA ECMO, 20 to 40%, probably closer to 20. If it's for resuscitative measures, failure to wean, we just had two, not too terribly long ago, who both did great. It was a temporary thing, 3-4 days, and we were able to decannulate them, and they did fine. But 3 or 4 days is going to be, they were centrally cannulated, so they were good. But if that was a peripherally cannulated case, there's no hospital that can afford $8,500 wouldn't even count, wouldn't even be day 0.5, half a day. And then with the VV ECMO, these patients are expecting to be taken care of. But, and it's just wrong. It's fundamentally wrong. A patient of VV is going to be on for 14 to 21 days. 7 days early if you really put it in early. But on average, I would say it's about 14 days. And at $35,000, again, that's just that's about 2 or 3 days, and it's gone. So the hospitals are just going to be essentially exsanguinating, just bleeding out a massive hemorrhage of money. and I think it's going to result in a pullback on the ability of the hospitals to offer it as a service, because the physicians aren't going to care.
The sad part about that, Joe, is
they're going to want it done.
I know in particular a few hospitals in the Houston area, and I'm sure, and I just know those personally because I know people that work there. You know, a lot of their I guess staffing and ability. I guess the reason they have so many perfusionists there is largely dependent on their ECMO programs.
Yep.
So I guess to come full circle with the first question that we talked about, will there be a flood in the market? Well, I guess if hospitals are shutting their doors on ECMO programs and you can't staff the number of perfusionists you were, maybe there will be.
Yeah, I think so. And Patrick says on this, he said, watching tonight regarding ECMO, think about number of patients who are on ECMO before they receive a transplant. Do you think that change in the ECMO DRG will affect the number of transplants? Patrick, that's that's a great question. I think that's a very good point, and one of the many really good points that are out there. So I'm glad you asked that question. But I don't know. I think it will. I mean, I don't know, because the physicians are going to take care of their patients. If you're a hospital that currently has an ECMO program, there's no way that a physician is going to say, it's too expensive, we can't offer this program, we can't offer this service to you. I don't think that's going to happen. I think it is, they're going to provide it. Something else is going to happen. And the hospital is going to have to either make the difference up somewhere, they may become more selective, but we're here to help people. We're not here to worry about cost. We do, and we all have to, and I think we all have to be good stewards of the finances of the places that we work. I mean, I think that's important. I think it's reasonable. But at this, we don't want to be wasteful, right? But at the same time, we're clinicians. We're here to help people. We can't say you're a 25-year-old, 35-year-old, 40-year-old young man, young woman with just, a couple of small kids at home, and you've got pneumonia and ARDS, but we're not going to support you while your lungs recover from your pneumonia and ARDS. I mean, when you've been doing that all this time, how are you going to do that? I don't know. So, good question. And on the transplants, again, a lot of patients on V ECMO that are on the transplant list, and now those hospitals are going to lose even more money because they're on it for months sometimes while they're waiting. So that's going to be a real issue. So getting back to the bleeding, which was the whole point of this, right? Tell us a horror story, if you will, of the Plavix days. Because you and I we bonded. We became very close during those days of spending nights, long nights in the operating room watching bleeding.
I would prefer you not talk about me and you with the word bonded and long nights together, but
it's you and I need to correct your English. You and I.
Oh, you and I.
Yeah, there you go. Yeah.
Is that better?
Yes. But we did. You don't want to.
You and I bonding and long nights don't need to be in the same sentence.
I understand, but talk about those days of Plavix when they would do that, and how we would manage that.
Well, the problem is like you said earlier, it's like a dog chasing your tail. I mean, I know you and I were there on multiple cases together back in the day. And unfortunately, you left and went on to greener pastures and left me there chasing my tail by myself. But I understand. Like you said, the problem with it is you give Plavix. It's a GP2B3A inhibitor, which means it's irreversible. I mean, the only way to correct it is by replacing the platelets that are in there. And I mean, you bleed and suck it to the cell saver. You're giving back PRBCs, bleeding, giving platelets, sucking some of those to the cell saver, giving back PRBCs. And I mean, it's a never ending battle. That the problem is even when you think you got it under control, you close the chest, you bring these patients upstairs. I guarantee you more often than not, you get another call back in the middle of the night saying, hey, we got to bring them back for a washout. They're bleeding.
Yeah. Yeah, there was a lot of that. So do you like, I have not seen a lot of cases just yet of patients who are urgent or emergent that are on these now these novel direct oral anticoagulants like the Pradaxa, like the Eliquis, like the Xarelto, and the other new ones, I guess, that are coming out. I don't have a whole lot of experience with it clinically, but I just know enough to go, I've seen this dance before and I know what the steps are, but I don't think we're prepared for it. Have you even thought about it, or have you seen it, one, yet, and were you prepared before this presentation, and will this give you some motivation to maybe figure out, man, I really do need to figure out what to do with this, because a lot of this stuff dealing with bleeding tends to fall on our shoulders. At least that's been my experience.
Yeah, no, I agree. No, I have not seen it from a clinical standpoint. And to be honest with you, I was not prepared. I thought the slides that you put up towards the end of, what to do in case they're on, this drug, what to do in case they're on this drug, are they protein bound, are they not protein bound, so forth. And so I thought that was an excellent starting point, and, something that, I'd be very willing to go sit down and talk with, my surgeons about, and say, hey, if they do come in here, we don't want to be doing what we did in the past. Is this something that we can consider and see, which direction, they'd like us to go?
Mm-hmm. Yeah, I think that's a really good point. I think I need to do the same thing. And because, we're not here. We can't solve all of the problem. I have limited clinical experience with it. I'd like to find somebody, if there's anybody out there in the audience right now who does have experience with this from a clinical perspective and wants to share that, please let us know. We'd love, of course, for you to be watching it right now and wanting to chat, or call in. We've got our phone on. But if you want to, in fact, you want to leave the note that our phone line's open, and we welcome your call. But even later, if you want to reach out to me or to Clint, we can put your email address up there too, Clint. You mind if I give you your email, or do you want to keep that?
No, I don't mind at all.
Okay, yeah. So Clint's email is Tioga06. So it's TIOGA 06 at AOL.com. And Tioga is a little small town in the very center of Alexandria, Louisiana, where they do strange things with chickens, but that's all right. But that's where, again, alligators. Yeah, Magic's saying, no, they don't have alligators. They just have chickens. The alligators are too afraid to go there. And but that's Tioga. And so it's Tioga06 at AOL, or mine. You know my email address already. It's jbasha at thenewOrleansConference.com. So, I'm going to be interested to see what happens with it. And then I think that really taking into consideration, Clint, what our experience was and how much we transfused those patients. Everybody thought, well, you just give some platelets, but that's not how it works. You'd give the platelets and they would be bleeding so much that those platelets would bleed, and you don't bleed just platelets. So you have to give red cells, then you have to give plasma, then you have to give cryo, and before you know it, your coag panel is so distorted, it's not even resembling anything close to normal, and it was just a never-ending battle, and I'm fearful that we're gonna have the same thing happen with this.
I think it's a very strong possibility. And I just wanted to bring this up because I was thinking about it. And I don't know if you remember this, and I won't mention any of the anesthesiologists by name, but I thought it quite funny when this first started happening, and they were coming in with 600 or 300 Plavix, whatever it is, and we'd get these patients in there, we'd do a platelet function, and they'd have a platelet count of 350, but their collagen would be well up on the plus side, but the ADP would be 10% functional. Right. And of course, they didn't want to give any platelets. They thought the platelet function test wasn't working properly. So we didn't have anything available. So then we spent, 30 to 40 minutes waiting, to call the blood bank, get the platelets up there. And then we were even that much further behind. And it took probably 3 or 4 of those patients coming in there before those guys were actually, well, maybe the platelet functions is accurate,
Yeah. Yeah. I'm not going to make any comments, okay? And I'm not going to say any names either. But man, I'll tell you what.
You know what I'm talking about, though.
Yes, I know exactly what you're talking about.
Okay.
So we would do our due diligence. We would get platelet function studies done, which is kind of like doing not a tag really, but so if you did a tag, it'd be the same result. They would look at it and go, "Oh, it's not right. Your platelet, it's just not accurate." And you get so far behind. But I think that what about the other places that you go? Are you still doing routine platelet function studies? And what do you think of tag?
I'll be honest with you. I think the tag has, if you know how to read it and you can interpret it, I think tag is very important. I think tag is a great tool to have. But like I said, with that said, there is a learning curve with the tag. Once you learn it, understand it, it's a great tool to have at your disposal. Platelet function test. In Alexandria, we are doing platelet function tests. Some of the hospitals that I go to in Florida, some of the ones that I go to in Colorado, we are. Mississippi, we're not. I've tried to get some of the smaller places that we go, some of those things implemented in, but it's kind of like fighting a losing battle. But matter of fact, one of the hospitals that I went to in Mississippi, we actually did have a tag. It sat on the shelf for about 8 months. We took over the contract there, and when we got ourselves in the door, they had sold this tag to another place and got rid of it. They got a new surgeon that came in there. I'm not making this up. 3 weeks after he gets there, the first thing he wants is a tag. And of course, he goes to administration. And administration is like, well, don't we have one? And, of course, we sold it and they went through a battle. He wanted it. They didn't want to spend the money now. And, of course, now we have nothing. So, But I guess to make a long story short, yes, tag is probably one of the best things to my knowledge that I know out there, as long as you have somebody that can interpret the results and knows how to use it.
Well, without tag or without platelet function studies, without being able to get a PT, PTT, INR, of course, that'll be affected if you're on these novel anticoagulants or these other things like that. And but basically, it comes down to 2-pack cells, 10 2-pack cells, 10-pack of platelets, 2 FFP, and a 10-pack of cryo. And everybody's going to get it.
That's right.
Get it. And the cost of that in just a couple of patients far exceeds the cost of buying a damn tag.
I agree.
Only takes one case. Takes one type 1 dissection. Although I remember, we're doing type 1s here, and I know we got to a point there too where we were doing those things and having the patients were dry, especially when we were ultrafiltrating a lot. And I loved ultrafiltrate. So how's that going for you over there? Are you guys seeing a lot? Are you still ultrafiltrating as much as we used to? Has it died down a little bit? Where's it at?
We still are ultrafiltrating. We probably ultrafiltrate on 90% of our patients to some extent. The other 10% is I'd say 5% of that, we probably ultrafiltrate on about 80% of our patients. I'd say 10% of that is one of our anesthesiologists doesn't want us to ultrafiltrate at all. And the only way that we get to is if we get one of our surgeons to say, hey, they're ultrafiltrating. Other than that, I think, most of them are, mainly on board with it as long as we keep it under control, I guess. So they say, but.
So if the patient is, in florid failure and is 15 liters fluid overloaded, that doesn't matter. So keep it under control. What does that mean? Because I've done those cases. We used to see that all the time, and not that many years ago. I don't see it that much at least, and some of it may be geographic, just where you are. But occasionally I get a patient out here that is really fluid overloaded, and we'll ultrafiltrate off 6, 8, 10 liters during a case. unless I'm doing one of those hyperkalemia cases. But I found it interesting that the Pradaxa can be pretty much cleared they called it extended dialysis. But normal dialysis run is 4 hours, but I wouldn't use dialysis. I would rather use CVVH. I even on pump, you could do it right there. And you've done those hyperkalemia cases with me, so it's not that hard to do. You just have to have the right fluid. You don't want to do this. In fact, my talk on Thursday, my webinar on Thursday, is about fluids. So fluid balance, fluid overload, types of fluids that we use. I'm going to talk a lot about these bicarb-based solutions versus the normal saline or plasmolite or the acetate-based solutions as well. So we're going to look at that. But anyway, any other thoughts?
Me?
Yeah, you. No, I'm talking to the other. Let me see. Is anybody in the studio audience that wants to ask Clint a question? Nobody?
I take questions, man. Just let me know.
Hold on. What's your question? Yeah. You. No. He just wants to know if you have any vodka.
Vodka, bourbon, rum, tequila, whatever you need, man. I got it.
All right, that sounds good. Hey, listen, it's been great seeing you again. I loved working with you, man. I miss you a lot. You're a great person. You certainly were an exquisite clinician, great perfusionist. I really learned a lot from you. I really enjoyed working with you. But I understand you've got a new daughter. You have your older daughter. You have Lainey. And then you have a new daughter. So how old is she now?
She just turned 3.
Just turned 3. So you're past the terrible 2s, and now you're into 3. So she actually probably likes you right now.
I think the terrible 2 spilled over to the 3. So
the terrible 2s to the more horrible 3s.
That's right. That's right.
That's good. Is she there with you?
No, they actually went to dinner, so I could speak to you. So.
Oh my God! So are they going to bring you something back?
I doubt that, seriously.
Or are you going to beat them out? Well, good. I'm glad you're being treated. I'm glad you're being treated at home like we normally are when we're at work.
That's right.
All right.
She took after you, Joe.
Say that again?
She took after you, man.
Yeah, no doubt. Well, listen, I want to thank you again for coming and doing this with us today. I hope that you will, and I hope that our other colleagues will take into consideration that, things are changing and evolving in the anticoagulation world. And, at the end of the day, we don't want to be there all night bleeding. And I think that we can be facilitators in managing these patients if and when, and I believe it's more when than if, we see them coming to the operating room on a more urgent basis. And then we have these bleeding problems. I think that what we saw with Plavix, I believe it's going to repeat itself as more and more people are put on these medications.
Mm-hmm. Well, I have to say, I hope you're wrong, but I think you're right. So
that sounds good. All right. Well, thank you. Once again, thank you so much. I'm going to have the guys shift things around and go to my closing remarks. And then I think we'll be able to finish up a little bit early tonight and bid everyone adieu. So for right now, Clint, I'm going to once again tell you that I miss you. And I hope someday that we can work together again, because I really enjoyed it. And I know you got a very long career still ahead of you, because I agree with you. Perfusion isn't going to go anywhere. It's just what we do is going to shift. There's always going to be the pump cases, but the peripheral stuff that we do is just always kind of shifting with new technology, and what people don't want to do, we're always happy to do.
Right. Well, thanks for having me, Joe. I appreciate it.
Thanks, sir. All right. Good night.
Night.